We have now the final run, a 2 hours run, and still we are very happy that so many people are joining us on a Saturday morning after a beautiful night experience. So actually we asked Guillermo Garcia-Manero to be here today to give what are really the expected emerging drugs, and which I hope he will try to really translate what we heard last days on biology and now translation, and he's really a clinical trialist from MD Anderson, and we are looking forward what are the perspectives in treatment of MDS after already a beautiful session this morning on multiple targets. But at the end, I would like to introduce Guillermo to give that overview, and we're looking forward to the future. Guillermo.
Thank you, Arjan, very much for this opportunity. This is actually really fantastic. The morning actually was incredible, so hopefully this will get a little 10% of what you expect, maybe. So, traditional actually at this meeting that I always enjoy, we have this kind of talks like the American perspective of how to treat this disease, European and so forth. I think this year is a little bit different because you're giving me opportunity to maybe tell you a little bit of what we're doing and maybe give it a little bit of context. And you know, the plan here is not to go and talk about like 100 drugs. Actually, indeed, this morning we heard a lot of them, and actually quite interesting. I think the question that as a community we need to start asking ourselves is, can we actually start changing the natural history of this disease? In other words, can we help our patients live a little bit longer? And traditionally when we talk about these diseases, we start with the low risk and then we go to the high risk. And here you're going to see that I'm going to go a little bit different. We've seen some progress. When I was a junior faculty in the early 2000s, we had kind of like the development of the hypomethylating agents. We approved like 3 drugs in 3 years. And I thought we were going to approve 10 in 10 years, and then I was going to retire, and then we had this hiatus. But actually the last 4 or 5 years, we had some improvements. You will say that these are more or less significant, but there's like, as you can see there, almost a drug or 2 approved for the last 4 or 5 years. So I think we're starting to see a little bit of progress. And then the other issue, and Bart Scott gave us a fantastic overview of this, is that it's becoming really apparent that there is this concept of what we're starting to refer to as total therapy, where, and there was some discussion earlier with Dr. Salman about whether this arm is not more or less randomized to transplant. I couldn't understand that very well. But the reality is this is becoming clearly something really fundamental in how we approach these patients. So I asked one of my junior faculty to look at all the experience at MD Anderson for the last 20 years in terms of transplant. And we see, and this is going to be presented at IHA, I believe, and ASCO. But to look, this is totally retrospective, single center, MD Anderson, but it's like around 800 patients or so. And we see a phenomenon where in the blue line in the bottom you see what happens in terms of survival for those patients that are treated with only a hypomethylating agent as monotherapy. And then the curves on top of that are those patients that are treated with that kind of drug plus a BCL2 inhibitor like venetoclax. And then the ones that are a little bit on top are those that are treated with some form of chemotherapy, let's say cladribine, cytarabine, venetoclax. I think this is quite important because we're starting to talk about the sequence of these therapies. And Dr. Salman was talking about this MRD and MDS, that again, I'm not sure exactly how that works, but actually that the intensity of the therapy prior to transplant appears to be very important. That is beyond what Dr. Scott was telling us in terms of reduced intensity or not. We believe that whatever you do before transplant actually matter, and perhaps some of these doublets or a little bit intensification of therapy prior to transplant is really important. So this is going to be a little bit in the back of my mind as I give this talk. So let's start first with the high-risk disease. And I think the task here is, can we improve on this single-agent hypomethylating agent activity? This is the famous 001 study. And today, or the last 2 days actually, we heard a lot about in terms of definition of high-risk disease and different approaches to improve on azacitidine. We heard all the stories about different doublets, targeted approaches. We heard from Lionel a few minutes ago. So I think we are starting to be in a situation where maybe we could get this done. Of course, That sounds easy to do, but this is the old slide from the 001 trial. Nobody has really yet been able to outperform this. And these are actually some of the recent doublets on this disease, and there are multiple versions of this slide, all of them failing, and maybe we heard the discussion the other day why. It could be many reasons. The reality is that we are all waiting, and we think that this data is going to come out at some point actually soon for the results of this study called the Verona trial. And I think this is actually going to be the major pivot in terms of what's going to happen in this field moving forward. So there is anxiety and there is a lot of speculation. Is this going to be positive or negative? It's kind of the discussion that we had the last couple of days here. The reality is that this was just published in Blood a few weeks ago. The response looks better than single-agent azacitidine with a complete remission rate of around 30%. If you look at the overall survival of this, around 26 months, looks good. Now, you can start saying, is this better than the 24 months from the 001 trial? The CR rate is 30, but in the Panther trial was 31. So all these kind of things. So of course we have to wait for the study. But there is another phenomenon from this study that was not really part of the paper. It was a presentation at ASH a couple of years ago, that actually a significant fraction of patients on this trial were transplanted. So it's going back to this theme, maybe actually confirming some of the data that I told you from the retrospective analysis from the MD Anderson. So these are people from this trial treated with ASABN, different doses, I believe, that were transplanted, and these individuals are actually doing quite well. So again, this is the concept of total therapy. And I'm not sure that we can really disregard this, or whether we have to in the future design studies excluding or including transplantation. We're waiting for this. This is the sign of the Verona trial. Again, this is going to be really, really positive and very, very important for us. And what do I mean by this? I think if the study is negative, whatever that means, in my modest opinion, we'll have to start thinking about getting away from an HMA backbone in subsequent phase 3 trials. I don't know actually how we can, like now, maybe this Clever One story will be the one, but I think that will be extremely difficult to really do. We fail in, that's a very small list of patients. If it's positive, it will be very important because it will be the new standard of care, although it's kind of already the standard of care in our practice. But I will build to what Lionel was telling us in terms of triplets or perhaps some of the other approaches I'm going to show you in a minute. Now, we are also starting to understand a little bit the dynamics at the cellular level of this treatment. So this is data at the single cell level, prospectively in those studies performed by Simona Cola and Irene Gagnan, who's now in Pamplona in Spain, but actually looking at different cellular compartments that respond differently in the context of this kind of therapy. So we define, for instance, what we call a CMP pattern and GMP pattern, and what we see, for instance, is that at the time of relapse, this could be quite important, they may express actually different pathways. So for instance, in one of them, MCL1 is quite important. So you could think maybe that this will be a situation where you could build on therapy with a triplet that may actually limit a little bit issues that you see with BCL2 resistance. The other issue that is starting to happen is the development of these oral compounds. And I've devoted quite a bit of my career to do this. So I basically performed the phase 0 trial with oral ASA, now approved in acute myelogenous leukemia. And with collaborators in a company called Aztecs, we worked very hard to develop these cedazuridine combinations. And this is quite important because when we did the CC486, this is basically just taking per mouth unconjugated drug with a limited exposure. Now, this is actually active, and this could be another story why the study failed in MDS. We actually heard a little bit about this from, I think it was Moshe in his talk yesterday. But the reality is that we were interested on developing compounds that actually gave us identical PK profile to the parenteral form of these hypomethylating agents. And this is actually by combining either decitabine or azacitidine with a compound known as cedazuridine, that is a cytidine deaminase inhibitor. There is another compound called tetrahydrouridine. We have no experience with this in MDS, or at least we don't have that. So what is the idea here? The idea here is that if you take per mouth decitabine or azacitidine, this is basically degraded in the gut, in the liver. Potentially, actually, there may be enzymatic activity in a specific cellular compartments in these patients. And basically, you have kind of lower absorption of those compounds. So the hypothesis here is that if you inhibit the activity of the cytidine deaminase, with cedazuridine, you may at some point actually get a pharmacological profile similar, if not identical, to what you have with the IV decitabine. So I have to say that this was a lot of fun to do. I mean, this small company, they don't really exist anymore. They're now part of Taiho, but they have a phenomenal pharmacological PK group. So basically, when we were doing this phase 1 trial, what we were doing is looking at different ratios of decitabine with the cedazuridine, trying to then correlate that with particular AUC of the drug. And if you look at the table, in the first cohort, it was 35%, actually very low, actually double of what you get with the CC486. And if you go to cohort number 4, it was 144, so we went too far. Actually, we were kind of readjusting this as we were doing these different cohorts and looking, of course, at toxicity. And then we came with the one that you see there, 40, 100. At the end, we decided on the 3500. So this actually, and phase 1-2 trial informed not only on toxicity, but also in very specific PK/PD characteristics of this compound. And then with that, we developed this trial called the Ascertain trial, published a couple of years ago. It was a randomized study, quote-unquote phase 3, where we're actually looking at different sequences of IV versus oral, so we could then, in each patient, compare the PK profile of the drug. And this was actually what the FDA wanted to see to get this drug approved or not. And what you can see here actually is, sorry, this is moving a little different, is that it's virtually identical to what you see with IV decitabine. So I don't know how we did this, actually, because it's a large phase 3 study with multiple centers involved, but really great to see that we were able to collect these samples and actually almost identically developed a compound that emulates the IV decitabine. Now that's nice, but the question is this drug active? It's nice to have good PK, but you want to see whether this works or not. So what we see in this analysis is that the complete remission rate with this compound was around 22%. There are patients here probably with lower risk disease, so this is not like, prospective, only high risk disease study. The median survival actually is around 22 months or so. Again, patients with lower risk disease. So the question is this really something that you can compare with the 001 trial or some other studies? But this data looks positive. Actually, this led to the approval of this compound in the United States for patients with MDS. And I understand a few weeks ago in Europe for patients with acute myelogenous leukemia. I'm actually quite proud of that. But then in kind of like pre-planned molecular analysis that we did in this study, we started to look at a specific molecular subset of patients. And there's been this concept that P53 mutated disease is perhaps a little bit more sensitive to these hypomethylating agents. Remember the story from WashU of the 10 days of decitabine, etc. So we looked at the impact of this compound in this group of patients. And then when we did the first analysis, and this was attached a couple of years ago, what you see, of course, is that P53 mutated disease did worse than wild type, but actually these numbers were not bad. 25 months median survival for P53 mutated disease. So intriguing that maybe there was something differentially a little bit more positive for this compound. So at ASH last year, we presented data from this propensity score matching analysis. This is actually kind of nice because the company was very generous in giving us their data, and then we compared this with our own P53 cohort of patients and then trying to match them. I mean, at the end, this type of analysis, you have to take them, in my opinion, as exploratory, so these are not definitive answers, but actually the p-value is significant with around 5 months improvement in overall survival. So this is not the end of the story for P53 mutated disease, but this is something that we're now doing kind of a standard in our practice, that those patients that are mutated outside the context of clinical trial will be hopefully preferentially treated with this type of compound. Now, what do we do next? Lionel was talking about doublets. So we're going into total oral therapies with these compounds. And this is the oral decitabine venetoclax. We're going to hopefully be able to update this for ASH. The study actually is being expanded as we speak. But again, preliminary data, but shows something that I think is quite important. So what we see, again, is that this compound may be a little bit more powerful, and I have no proof of this, but seems to be clinically quite effective. So when we combine the oral decitabine cedazuridine with venetoclax, the responses that you see there, overall response, is around 95%. There are details, for instance, like half of these patients achieve a complete cytogenetic response. This is something that we don't measure all the time. And actually, half of these patients go into stem cell transplantation. That I think, as Amer was asking later, may be actually something quite important for a subset of these patients. Now, how does this look in terms of overall survival? it looks actually quite positive, because I agree with Dr. Scott that I don't really see why we should really eliminate or not include P53 mutated disease in this kind of context, although you will see actually their overall survival very quickly. Now, there are some tricks with this data. The first one is this issue of the P53 mutational status that perhaps without the backbone of a transplant may be something that is not 100% guaranteed. But then someone in the morning was talking about this phenomenon of patients with AXL1 mutated disease being quite sensitive to this kind of therapy. So venetoclax plus an HMA, venetoclax plus oral decitabine cedazuridine, really giving you almost 100% response rate. And if you look at the panel on your right, actually really significant overall survival in this group of patients. So this is something that we're trying to understand now in our laboratory in terms of what mediates this kind of sensitivity to this doublet. Let's skip over this. And then, of course, like any of the other hypomethylating agents, this is actually a good backbone to do whatever you like, because this is an oral compound. So there are studies now in low-risk disease, and there are multiple combinations. Most of these are actually in acute myelogenous leukemia, not really in MDS, but something that we could incorporate into our own patients. So studies with IDH inhibitors, FLT3 inhibitors, very, very important, really powerful data with menin inhibitors, this so-called SAFE study with really high rate of response doing total oral therapy with menin inhibitor, venetoclax, plus this oral compound. And something that we're very proud, actually, incorporating this kind of therapies into pediatrics patients. It's easier for them to take this pill than some type of injectable. Also, this could have a role post-transplant, and there are some studies looking at this. And the next step is actually going to be probably something that is potentially going to have a little bit bigger impact than the decitabine cedazuridine. That is actually the same concept, but with azacitidine and cedazuridine. Why we did the decitabine first as opposed to azacitidine? I could explain it. I mean, the company that developed this compound actually was really important in development of the decitabine and so forth. So they had a lot of experience with this compound. But the reality is that azacitidine is the most commonly used hypomethylating agent all around the world. So we decided then to go and kind of design the same strategy, replacing the decitabine for azacitidine with the cedazuridine. And this compound is known as ASTX-030. Many of you probably are part of the phase 3 study that is ongoing. This is already accruing patients in MDS, potentially in AML, and hopefully in the future adding venetoclax. So this is going to be quite a bit of an aggressive phase 3 study. We presented the data at ASH with kind of the phase 1-2 PK toxicity profiles. I'm not going to spend a lot of time here, but it's the same concept. What is interesting, though, is that the substrate sensitivity is different between azacitidine, decitabine, and the cedazuridine, so the ratios are different. So we'll see what happens with this compound. Hopefully, this will be something that we can take to the finish line, and it will give us another oral hypomethylating agent, maybe one that you feel more confident using based on the survival data from the 001 trial that could become actually a really important drug for our patients. Now, I was not going to talk a lot about HMA failure, but Amer had a fantastic presentation with this new antibody. The reality is that there is not much going on in these patients. This is tough. He was talking about this on-time trial. The reason we got this paper in Lancet Oncology is I convinced the editor that it was important to publish the natural history of the disease kind of in a prospective clinical trial as opposed to retrospective type of analysis. So you see their survival 4 to 6 months. Earlier, there was some discussion about primary versus secondary failures. Hopefully, some intervention like this antibody that you were talking about will take us there, but there is very little right now for this group of patients. And it's sad because this actually was our main area of research maybe 10 years ago. There's also a story with the other one, actually quite interesting. Now, there may be some options for these patients. And this may be something, earlier someone was talking about social issues, insurance allowing for this test. At least in my center, we're very good at actually resequencing every patient at the time of failure, actually through the course of the disease. This is quite important, and this goes back to what Dr. Ades was teaching us earlier. That is, you will see emergence or clonal evolution of some of these mutations, so IDH2, IDH1, FLT3 is something that people don't think that happens in this disease. Actually, it does. It happens in around 15 to 20% of these patients. You can see them a little bit because the Y count goes up a little bit. Adding a FLT3 inhibitor in this context is actually quite effective. I don't have time to go through all these studies, but all this data has been published. There was an interesting question earlier in terms of enacidinib in patients with low BAFs, and I think Dr. Ades was right saying that there's really no good correlation with the amount of molecular burden and the activity of these compounds. I'm also intrigued by this, but I can tell you that the best data we have in HMA failure is with monotherapy with enacidinib, single agent, with a median survival of around 22 to 24 months. We don't have any other data. And how can that happen if the BAF is 10%? I don't really know, but it's actually very, very important. People talk about, other effects that these kind of oncometabolites could have in the stroma of these patients, but this actually is something very important. And it's sad, actually, that we don't have this drug approved for MDS. I don't know why the sponsor of this company is not really pursuing this, because it's something that could really benefit our patients. And the other side of this discussion is, as it was mentioned earlier, there is now actually a very nice study with ivosidenib that Marisa Berthe is leading here in France, looking at frontline, and there is an approval in the United States, I don't know, in Europe, for patients with relapsed refractory disease with the IDH1 inhibitor ivosidenib. So that actually is something important. Now, you say, is that really significant? If you do the math and you exclude the p53 from this table, because I don't think that we can do much for this right now, actually around 30 to 40% of these patients may have a mutation that may inform some therapy that could help those patients respond and have longer survival, or maybe put them in a situation for better stem cell transplantation. Now, let's go back to this issue that I started the conversation, that we all now agree that monotherapy with an HMA may not be optimal for transplant. This is something that we have done for like 20 years now. We're starting to see that perhaps adding something else to this HMA may help. And again, this is retrospective, non-randomized study, but I show you 2 or 3 slides suggesting this kind of sequence of some therapy followed by transplant, making these people longer. So the question now is, what about the backbone? Does this need to be an HMA backbone? So this data from the French group is actually quite interesting. Compound for like older AML with this CPX, total bridge to transplantation, very high rate of responses, and my understanding is that a significant fraction of these patients went into transplantation. At MD Anderson, actually, we are looking at this with kind of an attenuated schedule of the CPX, basically half of the dose with venetoclax, and this is actually quite active. But over the last few years, work by Dr. Kantarya and Dr. Kadia have been looking at this old drug, very cheap, called cladribine. I don't know if you have this in Europe or not, but this is becoming actually one of our most commonly used backbones in our program, both for young and older AML and now myelodysplastic syndrome. This actual data that comes from David Plunkett, looking at kind of low doses of subcutaneous cytarabine, conjunction with this cladribine, and adding now venetoclax. So this is work by Guillermo Montalban in our group. Here you can see the doses of this kind of triplet. So this is perhaps a little bit more intense type of approach, but not really considered intensive chemotherapy. This is actually quite well tolerated by a majority of our patients. This is a super busy slide, but it's actually quite an active program in terms of the complete remission rate. And then you see basically that this is now starting to be associated with improvement in survivals. And this is something that is becoming kind of our standard of a couple of cycles of this type of approach and taking these patients into stem cell transplantation. So to finish this part, I think the conclusions in terms of what's happening, and Arjan, I hope this answers your first question, is our view is that X something, whatever it is, HMA, cladribine, any other option, plus the BCL2 inhibitor followed by transplant can really result in long-term survival. We're talking survivals that now are close to 50% of our patients. And actually, I'm not sure why we're not really advertising this data more. Like, we're really negative here. Like, we don't get drugs approved. No, the reality is that some of these patients are doing well. Of course, they are younger, they have a donor, they can be transplanted, so we may not be talking about a total population of those patients. So this is going to be an issue. What is the real backbone of therapy? And this is going to all depend on these results of the Verona. Again, if that study is negative, we will really think about what to do next. We have huge need. One is P53. We heard from David Salman, beautiful talk in terms of the difficulties of this, and the HMA failure. It was refreshing to see some new positive, potentially, data in that context. Now I'm going to be a little bit more provocative, and it's the lower risk. And I asked this question to Dr. Fenot yesterday, I think it was, and I'm not sure if this question is kind of silly or maybe I'm kind of dreaming. But the question is, should we start changing the paradigm a little bit of how we consider low-risk disease? This idea of transfusion and quality of life that we cannot really measure. And this is actually interesting because these papers, they all start the same way. In low-risk disease, you improve symptoms, and in high-risk disease, you cure them. I say, wait a minute, like you have low-risk disease, you don't want to be cured or live longer, or that's not really important, I'm not sure. Anyways, so the reality is that probably we can do much better than this. Interestingly, and I'm not going to go through all this, all of a sudden, the treatment for patients with lower-risk disease is actually quite dense. We have luspatercept, imetelstat, the hypomethylating agents. The session this morning was really interesting. Indeed, actually, now it's getting complicated to think about how you design the next phase 2, phase 3, what will be the next drug in this particular context. But I think we are not, I don't know how to say this, I think we're maybe starting to see something that could be important, but I think we need to embrace this concept as a community. So the first time I heard Maria Diaz-Campello, I don't know if she's still with us or not, present this attach, I couldn't really understand it. I couldn't understand why giving lenalidomide earlier was good. The disease doesn't really progress very quickly. You can have high rate of response when you start this compound. Okay, why do you have to do this early? And the data that she showed yesterday, I think, is actually transformative. And it's not just transformative for the treatment of del(5q) minus MDS. It's a concept. You have an early intervention in this disease. You render these patients transfusion independent, like almost 80% of the time. And the data that she published in Lancet Hematology says that this is actually associated with a very high rate of complete cytogenetic responses. The study is not powered for survival, but I bet you $1 million if this has any value today, that this will be at some point associated with longer survivals. So I think we need to start thinking about this, not these heavily ultra-transfuse dependent patients that we're trying to put on these studies. So to me, this study is very important, this Sintra-Rep, not only for what it means in terms of early intervention in del(5q), because it's telling us that if we had drugs that were active in this context, we could start changing the natural history of the disease also in patients with lower risk disease. So yesterday, Pierre Fenot was telling us about these TGF-beta modulators. Then we have the COMMANDS trial that is, at least in the United States now, kind of a standard of care for a majority of our patients. There's a little bit of issues in terms of we treat RS positive disease or RS negative disease. The reality is that, at least at MD Anderson, we have adopted this drug as our frontline compound for most anemic patients. But that's not why I'm bringing this here, is that people are starting to show some of the analysis in terms of the impact of this drug or any other drug if you respond in the survival of these patients. So there are actually now 3 or 4 papers recently published suggesting the same phenomenon. And I'm not trying to say that this is actually luspatercept causing this. Maybe something else, or it may be a phenomenon that we need to explore. But I find this really intriguing. This is data looking at kind of analysis of some of these trials, and you see there that those patients that quote-unquote respond are doing better. Now, Dr. Fenot, when I asked him the question, said, well, they're doing better because they respond. And the question is that actually, and I say this with all my respect, is this actually really that easy? Is there something that we're missing before? And that's why Moshe was asking in the morning, what about combinations? I think this is actually very, very important. So French, Lionel has this study presented at us, this Combola study, name is kind of funny, but the reality is, if you come with this combination of high-dose luspatercept with an ESA, another response rate, instead of being whatever it is with a single-agent luspatercept up front, 60% or 70%, now this is like 80, 90%. Could this actually be, at some point, something that results in some durability of these responses and maybe improvement in survival? This is actually something extremely important in my mind. Now, there are a lot of different compounds. I'm not going to go through all of them. Some of them actually are totally negative in this list. But there is quite a bit of movement now trying to look at drugs that could have activity in this group of patients. Now, we now have a second generation, actually I don't know if this is true, but we have another TGF-beta modulator. Pierre was telling us a little bit about this. Again, Dr. Campello was the leader on some of the early studies. This actually looks quite positive. I understand this drug is kind of similar, maybe a variation of sotatercept, a drug that we had some years ago. This is going to be extremely interesting, right? Because if this TGF-beta inhibitor is going to have a role in our practice, we need to expect something from it that is kind of an additional value, either more responses, longer responses, maybe being cheaper. This is something, if Takeda is listening, will be quite important, because I think access to these drugs is really an important issue outside the United States. What about other pathways for improving erythropoiesis in patients with MDS? So this is actually, in my opinion, beautiful work also by Simona Cola in our group. And what she did here was actually to dissect at the single level, at the single cell level, using RNA-seq type of strategies, every step of erythropoiesis in patients with MDS. First, she did that in the SF3B1 mutated context, and then outside. And then what she discovered is this pathway. I don't know if I can use this. Here, this particular enzyme called EIF2K1, that is basically a major rheostat controlling autophagy in this particular step. So basically, if you inhibit this particular enzyme, then you prevent autophagic death in the earlier stages of erythroid maturation. So we're actually, this pathway is called HRI. It's actually quite important also for patients with sickle cell anemia, potentially thalassemia. And we now have a battery of compounds actually that inhibit this particular enzyme that are associated in vitro with an improvement in erythropoiesis. So we're excited about this. Our group for many years has been kind of dissecting this issue of innate immunity alterations in this disease. And this comes from an old paper by Yue Wei in our group, where she did a very simple analysis with a ChIP-seq strategy, technique that we don't really use anymore, but it's actually quite powerful. And to our surprise, in this experiment that we designed, looking at promoters that were in an on configuration of patients with MDS, the genes that we were finding actually were associated all with innate immune signaling, particularly things like toll-like receptors, IRAC, etc. Indeed, the presentation this morning in terms of this S100 inhibitor is actually quite pertinent. So these are actually some of these pathways in this context that have been described as part of this analysis and other data that you have seen here with Dan Starsanowski and others. But Moshe asked a very insightful question earlier this morning, and is that these are actually highly redundant. So let's say you block toll-like receptor 2, we've done that. You have some response, but not very high. You can use drugs that may, modulate the sting. You get some response, but not that high. IL-6, some of these things that were discussed this morning, they have already been done in clinical trials. I don't have really time to go through them. And then the question I think that you were asking is, how do we combine them actually? Should you combine IL-6 inhibitor with an IL inhibitor or with an sting inhibitor? I don't know how we will do that, but this is going to be an issue moving forward with some of these studies. Now I'm going to give you two brief kind of vignettes of recent data with some of these compounds from the last ASH meeting. There were some talks about NLP3 inhibitors. This is kind of an important module in this pathway. And you see exactly what I just told you. If you use a strict IWG, whatever it is, criteria, there are actually no responses here. But if you look actually at their transfusion rate, so these are people where the hemoglobin may not be that high, may not meet that type of transfusion dependency criteria, you see actually that there is kind of an stabilization on the transfusion needs of these patients. Zero toxicity. So the question now, at least with this particular inhibitor, is what do you combine it with? Because I don't see this as a monotherapy type of approach, although the study actually is now being amended to also treat patients with a clonal cytopenia of unknown significance. This is going to be very important from a regulatory perspective. How do we do this kind of studies, and how do you now do this type of combinations? Now, what I thought it was interesting, and it's not because this is a study that we were part of, is targeting this IRAC enzyme in patients with low-risk MDS. Now, this is kind of not tricky, but some of the compounds that cover this enzyme are also FLT3 inhibitors and click inhibitors. So these are actually very myelosuppressive compounds. This particular drug is very selective for IRAC1 and 4, with therefore a really excellent toxicity profile, particularly when we look at myelosuppression. Now, this is again phase 1, early phase 2, but it's a multi-center study, actually, not just us. And if you look at the group of patients that are treated, that are treated on this, that are treated here, actually multiple lines of therapy. And this is actually becoming my practice. I was telling last night David Valcárcel that we don't really have patients anymore for those big phase 2, phase 3 studies, because in the United States, these patients are now coming imetelstat failure, luspatercept failure, whatever third drug. So this is actually a major problem for us. So this compound that is blocking this kind of major rheostat downstream of a toll-like receptor, upstream of NF-kappa B and KDN6B appear to be quite active in this context. The next is this modulation of a particular cytokine, interleukin-1. And this is group work published by us not too long ago that I think is quite interesting. People have been talking about this in this meeting, about using this compound in clonal cytopenia of unknown significance. And someone actually was talking about regulatory issues, I think was today. It's actually very interesting because when we proposed this study to the FDA, they told us, no, you cannot do this. Now, this drug is approved, I think, for some disease called Mediterranean fever or something like this. So we were like kind of perplexed why we couldn't really use this in patients with these conditions, but they were very, very strict. So they told us, you have to basically use this compound in patients that had been exposed to at least 2 drugs with lower risk disease before you can do this upfront and before you can do that in clonal cytopenia. The concept is quite clear. We heard about this quite a bit. So in a paper that we just published a few months ago, we took a group of patients with really advanced low-risk MDS that probably are candidates actually for stem cell transplantation if they were younger. So this is their survival. And then what we saw is that there were just in this early first phase of the study, around 4 patients with a response, so minimal, 2 patients with actually a very good response, one actually was almost 4 years on therapy. There is something in the table that is quite obvious, that is the mutational burden is quite different. So we performed the study, we went at the single cell level, and again with the collaboration of Simona Cola, and I think this is actually the first prospective clinical trial where we use this kind of technology in these patients. It's actually fascinating to actually monitor the evolution through the course of the disease. We see actually different changes in their stem cell compartment. We actually understand the mechanism of resistance. You see, you block the interleukin-1, patient responds, it goes away, and the patient starts losing response. You acquire again a cell population that is expressing this particular protein. So what are the next steps in low-risk MDS? You heard a lot about CCUS. I actually strongly feel that if we were able to identify those patients with high-risk disease and you had some type of approach to block the disease from the beginning, that actually will be really transformative. These studies in early phases of the disease, like this ELEMENTS trial, this is for patients with transfusion-independent disease, randomized between luspatercept and the poietin, are actually quite important. I think actually where this field is going to go. And then I'm going to finish with a little bit of provocation. And I have 2 minutes, so let's see if I can make it these 2 slides. So when we published this medalist study, there was this phenomenon that responders live longer. And again, we didn't pay much attention. At ASCO and at IHA, you're going to see 2 presentations. I cannot really disclose it, I guess, but anyways, with some analysis, I don't know the results, you can figure it out, of the impact of luspatercept and responders in patients on the COMMANDS trial in terms of their survival. Now, we have not really digested this data, and you're going to see it in a meeting. But I think if we hypothetically assume that the survival of those patients could be longer, then the question is how a drug like this, that has no anti-leukemia effect in terms of what we know, killing leukemia cells, changes in BIFs, I mean, there's really no change in the molecular burden of these patients, could have an effect. And some of this actually, in my opinion, has already been presented without really us thinking in terms of what does this mean. So this is actually prospective analysis in the COMMANDS trial, looking at modulation of different cytokines and things like that in patients on the study. And you see a profound modulation, of course, of the TGF-beta. You see profound immune modulation of these patients. It turns out actually TGF-beta is important in heart function. So the question now, if we go to this issue of why patients with CHIP and CCUS have comorbidities and why these monocytes are floating in the myocardial tissue is, when we treat our patients, and I'm not just saying with luspatercept, let's say even with a hypomethylating agent, are these patients having a change in the natural history of the disease because the blasts are going from 6 to 4, or is because we are like modulating some other tissue, some other cell in some other tissue that is amenable to these molecules? I think this is something that we really need to understand. I don't know how to do it, actually. We've been thinking about this, how you build this in the context of clinical trials. Looking at comorbidities, looking at some of these other effects, I don't know. But we need to start measuring this beyond just the typical criteria that we have on clinical trials. And with that, basically, kind of some ideas, but I'm not going to go through this table of different approaches that I think could eventually improve the survival of our patients. And with that, Arjan, I really want to thank you for a fantastic meeting that you put together. Congratulations, and for this opportunity. Thank you very much.
Thank you, Guillermo. So maybe in the future, multiple myeloma like total therapy, whatever it might be, but we'll see. So because of our program, we have one small question. Detlef.
Yeah. Thank you very much for this fantastic outlook and for this giving us some optimism. I have one question concerning the not very good role of HMAs in the setting of allogeneic transplantation. I guess a lot of people, also we have observed that the phenomenon that after a temporary remission with AZA or decitabine, the clones which come up in relapse are even more aggressive. Could you comment on that? And could maybe the addition of VAN change this situation?
Yeah, okay. So I removed the slide, and maybe I should have left it. So I think this is a phenomenon that is obvious, but people don't really talk a lot about it. So we have actually looked at the stem cell structure of these patients in humans, in animal systems. Once you have full MDS, there is actually not a single normal stem cell. And I think actually that's the main difference between MDS and AML. And I think that's why the disease is more difficult to treat and cure even with transplant. So we need to remember that this is a disease of a more primitive cell. And once you have this disease, actually, you don't find a single cell that is normal. Yesterday, Dr. Savona was telling us how they use some guide RNAs in chip or something like this. That will be really the way to go. Why I'm telling you this? Because when we analyze by single-cell RNA-seq and also looking at mutational single-cell profile, azacitidine, decitabine don't touch these cells. So there's actually no modification of the primitive stem cell in this disease. That's why you have to give these drugs chronically. That's why when you stop the drug, these patients relapse. We have not seen this phenomenon of the clonal evolution that you guys have been talking. I think it's just fact that the drug actually does not really touch the true primordial compartment of this disease. What they do is actually induce differentiation of those cells. So you make more white cells, red cells, platelets, and that's actually associated with better outcomes. And I think that's why the data prior to transplant is not that clear, because it's not really, we call them disease modifying, but they are really not. So you may have some response, maybe some cytogenetic response, but you're taking the patient into transplant with the same amount of disease that they had at the beginning, even if you're calling that patient a complete remission. I don't know if this makes any sense. Now you're asking me, what happens when we add the venetoclax? We have not measured this, so I don't have any proof that by adding a second compound, there is some reduction in the molecular burden of these patients. I think that's very, very important. And what they were discussing earlier in terms of this MRD around transplant is actually something that we really need to understand better.
Thank you, Guillermo. Thank you for being here, and we have hope for the future with your view on that. Thank you.